Thank you very much for taking the time to view my presentation. My name is Chip Zeller, and I have the opportunity to present to you postpartum depression as a women's health issue. Postpartum depression is often labeled the aftershock of childbirth. Now, postpartum depression is a disabling but treatable mental disorder that represents one of the most common complications of childbearing. According to the DSM-5, postpartum depression is seen as a major depressive episode if the onset of mood symptoms occurs during pregnancy or within 4 weeks of delivery. Now, there are some frequencies to consider. In both clinical practice and clinical research, postpartum depression is defined as depression that occurs within 4 weeks after childbirth and up to even 12 months after childbirth. There are some other factors to consider. The estimated prevalence of postpartum depression ranges from 6.5% to 12.9%, and it can be even higher in lower income and middle income countries. There are some common effects of postpartum depression. It results in maternal suffering. It can result in diminished functioning and is associated with increased risk of marital conflict and an impairment in the infant caregiver attachment, as well as increased risk of impairment, emotional, social, or even cognitive development in the child. And in some rare cases, postpartum depression can result in suicide or infanticide. There are some other potential effects as well. Approximately 70% of new mothers have some type of mild depressive symptoms, often called baby blues, and they can peak between 2 and 5 days after delivery. And typically they include symptoms like weepiness, sadness, mood changes, irritability, and anxiety. Now let's look at our case scenario for this presentation. Here we see Clara. She's a 34-year-old Chinese American woman who brings her infant son Evan to the clinic for the baby's 1-month checkup. Now during the visit, the primary care physician, or PCP, asks Clara how she's adjusting to the role of being a new mom. Clara hesitates before answering and then becomes very teary as she responds. Not so well. She states that she's ashamed to admit that she has been experiencing a very dark mood and negative thoughts. She says that Evan wakes up every 3 to 4 hours during the night, and so the sleep deprivation complicates her struggle to stay positive and to have increase in energy. The PCP has asked me to consult with Clara. Now let's look at her demographic information again. She's a female. She is 34, and this is her first child. She's also of Chinese American race and has an ethnicity that is Asian, non-Hispanic. Now there's a lot of intersectionality that is present here. She's a female. She's 34, which might be considered old in childbearing years. She also is Chinese American. Her ethnicity is Asian, and they may have some cultural feelings about childbirth, cultural feelings about motherhood, cultural feelings about breastfeeding, and this has to be taken into consideration when we are helping Clara. Now, there are 5 phases of care that I will walk you through. The first phase is assessment, and this is where we look at her risk factors. We look at her behaviors and her symptoms, her attitudes, as well as her preferences. Second, we advise. These are specific personalized treatment options. These are goals to decrease her symptoms and promote a greater quality of life. Third is to agree. If Clara agrees, then we begin to work together to select goals with Clara's input, based on Clara's interest and based on Clara's motivation. Fourth, we would assist her. We would provide her with the information. We would teach her skills, and we would help her work to overcome the barriers that she's feeling. And the final phase is to arrange. And these are plans to provide her with long-term care. So let's get started. First, we would assess. We would administer a 10-item Edinburgh Postnatal Depression Scale, or EPDS. Then we would score it. Clara has scored a cumulative total of 20, but what does that mean? Now, the scale consists of 10 short statements, and Clara would be asked to check off one of 4 possible answers that would determine how she feels about herself. The total score is found by adding together the scores of each of the 10 items. Now, a mother who is scoring above 12 or 13 is likely to be suffering from depression and should seek medical attention. With a score of 20, Clara is assessed as having major depressive tendencies that do require immediate care. Along with assessing her with the Edinburgh scale, we would also like to use the PHQ-9 or Personal Health Questionnaire. This consists of 9 questions that would assess the presence of each of the symptoms of depression, and we would do the frequency of this based on the 2 weeks of evaluating it and rating it from a scale of 0 to 3. So she would have to think about the frequency of this and of these symptoms in the last 2 weeks. Now, as I've said before, with a score of 20 on the EPDS and a high score on the PHQ-9, both scores carry a very fair correlation. So we can assess Clara as having a major depressive tendencies, and it does require immediate care. After we assess, we would advise. And the next phase of this care is to advise Clara on the information that was gathered when we looked at the results of both the mental health questionnaire and the Edinburgh test that we administered simultaneously. We would present treatment options. Now, since Clara was recommended by her primary care physician, PCP, along with her high scores on both assessment screenings, we clearly communicate to Clara that her depression symptoms would be categorized as severe. Because they are severe, we have to take rapid action. We would provide her with antidepressant medication. And this antidepressant medication is recommended when symptoms of postpartum depression do not resolve with psychological treatment alone, when symptoms are severe and require rapid treatment. We would also carefully curate a therapeutic counseling model to go along with her medicinal treatment. Clara has agreed. Now, once she has agreed to our terms of cooperative care, client does express some reservations with medicinal treatment as she does want to breastfeed. Now, we must take this into cultural consideration. If breastfeeding is her cultural preference, we must research antidepressant medication that will not interact negatively with breast milk. So I would do a pharmaceutical research. In new onset postpartum depression, sertraline, the generic version of Zoloft, is often recommended as first-line pharmaceutical therapy because it does not pass through breast milk. From this perspective, with giving her the information that an antidepressant that we have found will pass minimally through her breast milk, she can keep breastfeeding, we then provide her with additional treatment options. We've already covered antidepressant medication, but now we're going to introduce her to a new mother's group therapy. We come up with goals for her as well. In this agreement stage, we go through Clara and ask some goals. We prescribe some goals that she could consider. First would be to have better sleep, to keep a sleep journal, to encourage her to sleep when the baby sleeps and not feel guilty about it, and have a goal of recording 8 hours of sleep daily, not just nighttime sleep, but 8 hours of sleep in a 24-hour period. We would also arrange for her to attend a small group of new mothers. And third, we would ask her to self-administer sertraline once daily in the morning. Now we have to assist her with this. Now we have to let her know that untreated postpartum depression affects the health of the woman, the infant, and the family. We will assist Clara by providing her continuous streams of information about the signs and symptoms of postpartum depression and its effects. In the assist phase, we have informed Clara of her diagnosis. We have had her assessment scores explained to her. And we have given her information on therapeutic options, pharmaceutical measures, and personal goals. We've assisted her with enrolling in a new mother's therapy group. Not just a group based on other moms who also have postpartum depression, but just moms who are new mothers, as there are many effects of new motherhood. This would offer her peer support. We've also advised her to have interpersonal therapy or cognitive behavioral therapy, either individually, in a group format, or online, since these are effective treatments for severe depression. Now we have to arrange. What does it look like to arrange for long-term care? Now, in women with postpartum depression, we would add CBT measures. Cognitive behavior therapy reduces depressive symptoms more effectively than pharmaceutical care alone. CBT will be delivered in 30 to 90 minute group or individual sessions over a time frame of 6 to 12 months. These sessions will be once weekly for the first 6 months, and then bi-weekly after 6 months, all the way up to the 12 months. Clara will be contacted by phone, text, email, telehealth on those off weeks of in-person therapy. So after 6 months up to 12 months, we would have her do bi-weekly. Then in the alternating weeks where she's not meeting, we would call her, text her. We would do telehealth just to make sure she's still doing well. Then the Edinburgh and the PHQ-9 assessments will continue to be administered at 3, 6, 9, and 12-month intervals. Now, each phase requires a personal action plan. A personal action plan is Clara is going to receive this personal action plan. It will include input from her in collaboration with her therapeutic team. We've laid out some goals. Attend a new mother's group. Attend individualized cognitive behavior therapy. And self-administer her sertraline. We have strategies. We need to prevent fatigue by requesting that Clara learn to sleep when the baby sleeps without feeling guilty. We've asked her to have a goal of 8 hours of sleep daily, not just at night, and to keep a sleep journal. There's a follow-up plan in place as well for her. Clara will be asked to take an Edinburgh postnatal depression scale at the 18-month point past when therapy first started. And Clara will also be given opportunities to evaluate the programs that we have asked her to be enrolled in. Then we will share. We will continue to share the action plan. And this action plan will be shared with Clara's interpersonal care team. And the plan will be evaluated every 3 months with Clara. We will have team meetings along the way. And in these team meetings, we will conduct them with Clara and we will receive her input. And this collaboration will help Clara own her postpartum depression. It will also help Clara feel like she is progressing, that she is taking action, that she is meeting her goals, that she is meeting her follow-up plan, that she is engaged in her strategies to help her overcome her postpartum depression. I want to thank you all very much for watching this presentation, and I look forward to your feedback.